هلا الكرونيك رينال فيلر refers to irreversible loss of renal function. يعني هي عباره انه irreversible ما بنقدر نرجع لحل الكلى الاصليه. تمام، احنا بدلنا هذا الاسم بالكرونيك كيدني ديزيز.
هلا بال 2007 تغير كرونيك رينال فيلير تو كرونيك كيدني ديزيز النيمينج.
تمام. هلا الباثوفيسيولوجي ايش السبب الرئيسي للكرونيك كيدني ديزيز؟ هو عباره عن progressive destruction of nephrons with hyperinfiltration and compensatory hypertrophy of remaining nephrons. يعني بصير hypertrophy للنفرونز وبصير في hyperfiltration. That maintain glomerular filtration rate. يعني بس يكون الجي اف ار نورمال ما بتاثر. This occurs regardless of cause of renal injury. However, the hyperfiltration and hypertrophy resulted from damaging increase in glomerular capillary pressure, which lead to glomerulosclerosis, interstitial fibrosis, and glomerulosclerosis. هلا المانجمنت تبع الكرونيك او clinical manifestation and their management. هلا بتصير في uremic syndrome. In the presence of renal failure, metabolic abnormalities such as anemia, academia, hyperkalemia, hyperparathyroidism, malnutrition, and hypertension. هدول كلها اشياء بتصير مع اليوريميك syndrome. Uremia is usually seen after creatinine clearance falls to أقل من 10 millimeter per minute. Although some patients may be symptomatic at higher clearance level. This is especially likely in diabetes and in those whom renal failure developed acutely. Uremic syndrome is characterized by nausea, vomiting, fatigue, anorexia, pruritus, weight loss, and change in mental status. These are no single uremic toxin that account for all of these clinical manifestation of uremia. Parathyroid hormone, beta-2, microglobulin, asymmetrical
dimethylarginine,
oxidative stress, and other toxins molecule may contribute. The presence of uremic syndrome is an indication to initiate renal replacement therapy.
يعني renal replacement therapy means one of two, whether dialysis or kidney transplantation.
Metabolic and electrolyte abnormalities, volume overload, and hypertension. Extracellular and total body volume expansion generally become manifest when GFR falls to أقل من 10 ل 15 ملم. At higher GFR, volume overload can occur if the ingested amount of salt and water exceed the available potential for compensatory exertion. Patients present with hypertension, peripheral edema, and pulmonary edema, the combination of dietary salt restriction and blood diuretic are the major treatment of volume overload in chronic kidney disease patients. Dialysis or ultrafiltration. Hyperkalemia, maintain in potassium exertion and excretion, at near normal level is generally maintained until the GFR falls to less than 20 ل 25 ملل per minute, or patient become oliguria. High potassium intake, low serum aldosterone level, type of IV RTA antagonist of the renin-angiotensin aldosterone system, adrenergic blockers, non-steroidal anti-inflammatory drug, NSAID يسموه يعني, methylbrine or heparin, academia, lack of insulin and increased tissue breakdown, potassium-rich food, potassium sparing, diuretics, hemodialysis is the indicated of refractory hyperkalemia. Metabolic acidosis or acid-base balance is normally maintained by the renal excretion of the daily acid lead, about 1 MEQ per gram daily, derived mostly from the metabolism of sulfur-containing amino acids. A rise of ammonium excretion can prevent acidosis until the GFR is below 40 ل 50 ml per minute. A decreased titrable acid excretion due to decrease phosphate excretion can contribute to a reduced net acidic exertion. Anion gap acidosis, اللي هو ال ESRD, is due to the retention of phosphosulfate, urate, and heparin and hyperurate metabolic acidosis accelerates bone loss, increase skeletal muscle breakdown, and reduce albumin synthesis. Alkali therapy to maintain the serum bicarbonate concentrated أكثر من 22 is a recommended sodium bicarbonate in a daily dose of نص لواحد is the drug of choice. As GFR decline, P is returned and stimulates parathyroid hormone secretion by reducing ionized calcium level and inhibiting the renal hydroxylation of 25 OH D3 to its active metabolite. هلا 21% OH2 2D3, the amusing fall in active vitamins level decrease intestinal calcium absorption, reduce serum calcium, and further increase in parathyroid hormone secretion. Parathyroid hormone increases renal phosphate excretion as the GFR falls below 30 milliliter per minute. Parathyroid hormone can no longer increase renal phosphate excretion, but continues to promote phosphate release from bone, resulting in persistent hyperphosphatemia.
Which is the cause of pruritus.
Hypertrophy and hyperplasia of parathyroid glands lead to high turnover bone disease known as osteolysis fibrocystica. Osteomalacia from aluminium accumulation and vitamin D deficiency. A dynamic bone disease is a low turnover state characterized by decreased number of osteoclasts and very low rate of bone formation. Predominant bone lesion in patients on dialysis, major risk factors. Peritoneal dialysis, older age, diabetes, increased calcium lead, and oversuppression of parathyroid hormone with vitamin D, analog, and calcium-based phosphate binder. Early treatment of hyperphosphatemia with phosphate binder and the use of synthetic vitamin D analogs is effective in preventing these complications. Dietary phosphate should be restricted to 800 ل 1000 milligram per day. Calcium carbonate, calcium acetate, phosphate binder should be taken with meal to bind dietary phosphorus. Serum calcium concentration should be maintained ل 8.4 ل 9.5 milligram. Calcium phosphate product should be kept at أقل من 55 ملغ. CV limer, lanthanum carbonate. Aluminium hydroxide should be avoided because of aluminium toxicity that manifestate as osteomalacia, anemia, bone and muscle pain, and dementia. Calcitarol effective in suppressing parathyroid level. Acalcate reduce parathyroid secretion and
Sinacalcet. Now it is the drug of choice. Sinacalcet. It is calcium mimic agent.
Sinacalcet reduce the parathyroid secretion and hyperplasia of the gland. Target serum intact. Parathyroid should be 800 pg لكل ملغ for those with ESRD. Parathyroidectomy. With anemia, bleeding, dialysis, platelet dysfunction in dialysis therapy is effective in restoring platelet function. Hypertension, 80 ل 85% of patients with chronic kidney disease increase in parallel with decreasing GFR. Water and salt retention increase activity of the renal angiotensin system. enhanced activity of sympathetic nervous system, erythropoietin, impaired nitric oxide synthesis. The chronic kidney is considered as okay. هلا بنحكي عن البيري
considered as هاي المهمة بالقصة.
CKD risk.
CKD coronary artery disease. يعني uremic patients are liable to get cardiac problems, and the leading cause of any death in renal patients is cardiac cause, not renal cause.
Pericarditis, uremic pericarditis is seen in 6 إلى 10% of patients with advanced chronic kidney disease who are not yet on dialysis therapy. Pericardial chest pain, dyspnea, and fever intensified dialysis without anticoagulants may be effective in treating pericarditis. Dyslipidemia, hypertriglyceride, elevated lipoprotein antigen level, and low level of high density of lipoprotein cholesterol. The total cholesterol concentration is usually normal or low due to the malnutrition or chronic inflammation. Low serum total cholesterol value in ESRD paradoxically are associated with increased mortality. Target LDL
low density lipoprotein.
الكوليسترول is أقل من 100. الدايتستين is a slow release أو nicotinic acid. Gastrointestinal symptoms: anorexia, nausea and vomiting, diarrhea, GI bleeding. Skin manifestation: dry skin, pruritus, ecchymiosis, pigmentation, easy bruising, uremic frost. Neurological disorder: fatigue, lethargy, sleep disturbances, headache, seizure, encephalopathy, peripheral neuropathy, restless leg syndrome, paresthesia, motor weakness, and paralysis. Glucose intolerance, hyperuricemia, malnutrition, failure to
thrive. يعني نقص النمو. especially in children. بيكونوا dwarfism عندهم دائما القزامة. failure to thrive.
Amenorrhea, decreased libido, sexual dysfunction and infertility, depression and anxiety, psychosis. Patient with chronic kidney disease should be referred to a nephrologist. Early creatinine concentration exceed 1 ل 2 ل 1.5 milligram in women and men, respectively. Glomerular filtration rate is less than 16 milliliter. Lower cost or decreased morbidity and mortality. Identification and preparation of renal replacement therapy. Dialysis, functioning access, placement of renal allograft. Factor contributing to the progression of chronic renal failure: degree of systematic and intraglomerular hypertension, severity of proteinuria, glomerular hypertrophy with increased vessel wall stress, hyperlipidemia, increased low density lipoprotein, LDL, low density lipoprotein, and impaired prostaglandin generation with the use of non-steroidal anti-inflammatory drug, high protein diet, persistent metabolic acidosis, and increase in ammonia production extends to tubulointerstitial disease. Thank you.
Thank you, دكتورة. افتحينا على الهايبونتريميا. Look, يعني chronic kidney disease, how many symptoms it does. فيعني chronic kidney disease, it is a very serious disease. يعني about 20% of people worldwide are with end-stage kidney disease. So take it seriously. بس كم سلايد والله دكتورة؟ That's good. شكرا دكتورة، وسجلي اسمك مشان